I'm Gordon Mazibrada, one of the neurology consultants from Queen Elizabeth Hospital here in Birmingham. Well, thank you for giving me this task. And the way I took it, basically, I wanted to criticize and be as critical as possible, not too critical about the stopping criteria. These are my disclosures. I'm guilty as everybody else, I guess. So these are two objectives. First is to review NHS proposed stopping criteria, and are they reasonable? Okay, so this is what we really need to discuss and maybe come with some answers. And can they be implemented at a national level? So number one, and this is the treatment algorithm published not long ago on the 4th of September, available. And these are the common stopping criteria. Okay, so number one, no reduction in frequency or severity of relapses compared with pre-treatment phase following adequate exposure to the DMTs. And that's the minimum of 6 months, or intolerable adverse effects to the drug or of the drug. Now, criteria 1 and 2 may lead to switching to alternative DMTs. Then we come into criteria 3 and 4. So number 3, development of inability to walk, that's EDSS 7, and I'll discuss that later. And then persistent for more than 6 months due to MS. And then confirmed secondary progressive disease with observable increase in disability for more than 12 months in the absence of relapse activity, and the EDSS of 6 or greater. This is a rare phenotype, and I'm not going to be discussing this. Obviously, criteria 3 and 4 will lead to stopping all DMTs. Right, so this is just a slight caveats, obviously. So if the drug is stopped for a reason other than intolerance or lack of efficacy, like pregnancy, breastfeeding, clinical trials, etc., that it may be restarted regardless of criteria. And obviously, if we stop the treatment altogether, I think we should provide adequate care in terms of MS support, including neurorehabilitation support. Right, so this is an algorithm, and it's pretty straightforward. So this is second-line therapy for relapsing remitting MS with disease activity on first-line therapy. So if this is your first-line drug, and you have disease activity, then you can go this way. Now, obviously, there's no ocrelizumab here, but we were told earlier today that this is going to be changed and updated in the very near future, hopefully not 2 years. And where ocrelizumab will fit, we don't quite know. In terms of rapidly evolving severe RMS, you can treat patients with alemtuzumab, cladribine, natalizumab, and then change them around if a patient fails. There are a few notes. I'm not going to bore you with that. They are quite obvious. There's something about cladribine, something about fingolimod, but it's a useful additional information to the criteria which they listed. Now, on to disease activity on second-line therapy. So if you already tried one drug and then you're now on second-line drug, and you fail, these are your options, including stem cell treatment. So that's now included in criteria. I think this is a good thing. If you become rapidly evolving severe RMS, then you can be treated with natalizumab. And then with rapidly evolving severe RMS who fail, you go this way, including HSCT. Again, there will be a role of ocrelizumab in the future, I guess. And again, a few notes, just a few lines about each of the notes in the algorithm. Now, intolerance, again, it's pretty straightforward. Anything goes. It's just interesting that if you are intolerant to alemtuzumab, if you're intolerant to any of these, you can't be on alemtuzumab. Fair enough. And then, again, 2 categories in terms of one relapse in the last 2 years or rapidly evolving severe RMS. I don't think there's any big debate about this. I think it's pretty obvious, and I think we can all agree on that. Now, again, a couple of notes about especially the JC virus, which I'm going to skip. Okay, now I have a slight problem with it. I think we probably need to discuss this a little bit later. So development inability to walk and EDSS 7 persistent for more than 6 months due to MS. Now, if you look at the definitions, so I took a few definitions from the web. So MS Trust definition and MS Society USA, if that matters. And neurostatus, I think we all trained, whoever has done any clinical trials should pass this. So what they say here, so this is inability to walk. But then the actual definition of EDSS 7 is unable to walk beyond approximately 5 meters with aid. So I guess you are able to walk 5 meters, but not beyond that. But this is not, it doesn't really equal to inability to walk, into my understanding, and maybe I'm completely wrong. And if you look at the neurostatus, which is slightly odd in terms of definition, their definition of EDSS 7.5, unable to take more than a few steps, but that's still walking, okay? And then EDSS 8 is essentially restricted to bed and chair. So I just wonder whether we should say development inability to walk, EDSS 8, persistent for more than 6 months due to MS, and of course in absence of recent relapses. Now, number 4, confirmed secondary progressive disease with observable increase in disability for more than 12 months period in absence of relapse activity, and EDSS of 6. So for that I've asked myself 3 questions. So what is the frequency of relapses in SPMS? If we stop the drugs, what happens? Then what is the contribution of relapses on disability accumulation and progression in SPMS? And then finally, is there a rebound inflammatory disease activity after discontinuation of DMTs in SPMS? Right, so I think we all agree that relapses decrease over time, and especially with secondary progressive MS, there's a good evidence that you relapse less and as compared to early course of the disease. But there is some evidence to say that the patients still relapse. And I kind of stumbled upon this paper, which quote 29.5 or 30% relapses in patients who have secondary progressive disease. So that's a reasonable number. And then most acute within 5 years, and mainly in patients who are younger. And I think what I did at the end of the paper, they essentially suggested that DMT should be continued for up to 5 years in SPMS, especially in this group of patients who are younger than 55. Now, what is the contribution of relapses on disability accumulation and progression? Again, I think overall the evidence is not in favor of relapses being significant in contributing to the progression. And then once the relapse occur, they have marginal non-significant impact of EDSS 6 in short term, medium and long term. And these are the references I quoted. Now, last question, is there rebound disease? And again, one of the papers, relatively recent, you can say, well, it's a small number of patients. We're talking about interferon beta and glatiramer acetate. And again, they found relapses in about 30% of patients, so 1/3. And then 5% of them had relapses which resulted in increase in EDSS score. So this is something to think about. Okay, so cases. This is one of our patients from the QE. So she was part of a SEN trial, and 5 months prior to her presentation in March 2016, she presented with severe disabling relapse. So she was essentially off her legs. And this is just a slice T2. You can see these 2 new lesions. They haven't done the contrast scan, but there was evidence of new inflammation on the diffusion-weighted imaging. I think she had another relapse after that, very disabling, and I think that probably contributed to her progression. Sadly, she died a few months ago. Okay, now, do we know about that? Again, small numbers, and you can criticize me about that, but this paper from 2011, so if you stop Tysabri, these are secondary progressive patients, you can see in some patients increase in disease activity. And this is a similar one about natalizumab, where a reasonable number of patients, even though the numbers are small, develop more in terms of inflammatory activity after they stop Tysabri. So are they reasonable? I think 1 and 2, yes, but please include ocrelizumab. With 3 and 4, I have some problems and issues with EDSS. I think we obviously need to discuss that and maybe make some recommendations. And there is a reasonable evidence of rebound disease post-natalizumab. Gavin is very passionate about upper limb function. And that's obviously a different topic. And don't forget, treat the patients, not the disease. And then just a brief one about how do we implement them. I think we should probably start with our own house or put our own house in order. And this is where I come from. So we have a big new hospital, big mortgage. Population is 4.5 million, a large geographic area. So it's Hereford, Worcester, Wolverhampton, Tamworth. So it's a big geographical area. As of November 2016, we have 4 MS consultants, amazing, 4 MS nurses. We have MS team coordinator, and she's absolutely brilliant and crucial in our service. We had a MS research SPR. She's now in London, and then roughly 14 I counted regional MS nurses. So not a very good slide in terms of the graphs, but this is we started here somewhere 97, 2000. Some know that better. And obviously, if you look at the number of drugs, so we have now 13 drugs. This made a big impact to our service in terms of monitoring, obviously. I was the only one until 2009, and then John Walmore joined. Then we appointed another niche, came in 2016, and then as of earlier this year, there's 4 of us. But look at the number of patients, around 2,000. So there's obviously a disproportionate increase in number of drugs and the number of patients we're treating to number of us. How are we going to go forward? So I think we like MDT meetings. I think they are very valuable. We have a dedicated neuroradiologist, and that's very useful for us. I think it's key to increase the number of relapse clinics, because this is the best way, I guess, to identify patients who are not doing well on treatment. I'm about to start SPMS and pwMS clinic, unmet need, definitely. Original plan was that we start hub and spoke service, but then for that we need more of us. We would love to appoint MS pharmacists, and allegedly we have some money somewhere in the system, but nobody's actually making any noises about that. In terms of the management, we are, but they're keeping quiet. We're planning to appoint more research fellows in the future so they can do clinics and research clinics. Some calculated that we need additional 2 band 6 nurses, and then healthcare assistant would be useful. Linked with regional centers, absolutely crucial. And then IT. So one of the things which is really frustrating is inability to access MRIs from the district general hospitals. There is a system in place. It's just very, very slow and doesn't work, and you can't afford to sit and wait for something to respond for 5 or 10 minutes. We tried with databases twice locally, and we failed twice, so hopefully 3rd time lucky. I had a discussion with the IT service at the QE, and they're working on word recognition software. The software will be able to pick up certain words like EDSS score, relapses, examination findings, etc. But that's, I guess 5 to 10 years before it's working properly. We tried with this with the help of one of the drug companies, Lesion Quant. It looked great on the paper, and this is to use a computer software to count the number of lesions, to measure the volume of MS lesions, and then to measure the volume of the brain. And that the plan was to use this as a routine imaging tool. but it doesn't work. It's giving wrong readings, so we abandon that. Virtual clinics, etc. And then obviously implement a nationally agreed standards for MS patients' care, and hopefully we'll come to that. Obviously there's a plan B, and that's a plan B. So.
Thank you. Thank you. Questions around implementing the stopping criteria and stopping criteria? Jeremy, you want to make a comment?
Just a point, really. The MS Register have been looking into word recognition software to extract the similar sort of information. You might want to talk to Rod Middleton about the developments they've made.
Yeah.
Show of hands, who implements the stopping criteria? Secondary progressive disease? So there's a scattering. EDSS 7? Okay.
I mean, do we agree on EDSS 7? What's that? Is that inability to walk, or maybe a few steps?
Well, the EDSS 7 is what it is. It's you can't make 10 meters, so it's less than 10 meters because you. Everybody's too quiet here.
I think all of us are uncomfortable with this.
I know we are uncomfortable.
I think I was a minority report, but not alone, at the various meetings with the algorithm, because I think we're getting a little bit of evidence now. That paper that you quoted is important, isn't it? That a third get activity after stopping, even in that older age group. So one of the things that I think we have to push on is that if people come off, if they do get activity, they can go back on, and we don't have agreement on that.
What I want to suggest is that we put together a group of people who design a randomized withdrawal study to actually get evidence within the NHS system to test these stopping criteria. Because I do think we have an opportunity here, if we are forced to stop them, is to do a randomized intervention study to see if continuing disease-modifying therapies beyond, be it SPMS at EDSS 6 or the 7 stopping criteria makes a difference. I personally feel very uncomfortable based on we had 3 patients from the SN trial that did so badly. Ben Turner was our PI on that trial that we had to put them onto disease-modifying therapies, despite them having secondary progressive disease, because they had such bad rebound after stopping natalizumab.
If you design that study, it's important to look at what supports in designing that study, it'd be really important to look at what support those people need to come off drugs, because sometimes they're so dependent on them. So it's important to see what carers, nurses, district nurses they're having.
But at the moment, we meant to just take them off the drugs.
No, I know.
So it's not like we... Yes, okay. Anybody else want to make any comments? Yep.
Comment or question?
Thanks, no, it's comment. I think because EDSS 7, it's all around mobility, and as you very well know, it's about upper limb function as well. We've all had people who, we've got patients who hold very meaningful jobs, who are wheelchair dependent, have got good upper limb function that would fall out of the criteria. You take them off, they have a relapse that affects that function, and they're more dependent upon services.
I think you're absolutely right. I mean, I have a patient with SPMS, and every time she comes in, she said that she's absolutely fine, but she can't move her legs and can't move her left arm, but her right arm, which is her dominant arm, is still working. And she thinks that she's doing very well. And she's happy with the situation.
The other thing I've always been slightly uncomfortable about, there is a logical non sequitur, because actually the starting and stopping criteria for second progressive MS are the same. So you can be indolently progressing with relapses, you go into treatment, you continue to indolently progress, and then you've got to stop the treatment. So it's illogical. And I certainly take the view about the extra support, because it is sort of Matthew 25, those that you have not, even what they have will be taken away. People are really bereft when you take them off their drugs and say cheerio from the DMT clinic.
I think we're all saying the same thing. One of the issues is, as you lose limb function, sounds the very obvious point, but what's left is ever more important. And the patient you mentioned with 3 limbs gone and with 1 limb functioning, the function of that limb basically decides that person's independence. And really, this idea of removing anti-inflammatory drugs at this stage just seems somewhat ridiculous. I appreciate that we're data-driven, and I appreciate we need the data, but there is an element of it being rather silly logic if that is exactly what you're trying to preserve.
But there is a good evidence that a small proportion of patients with relapse, and that will add to to their EDSS progression. So there's no doubt about it. If they're younger, it's likely to happen.
So if we just step back and go back to the pathophysiology, we've just finished an analysis of some post-mortem data of secondary progressive MS cases who are dead. Okay, so this is end-stage disease, obviously. And we quantified the lesion burden, but also the activity of the plaques. And over 60% of the cases at death in the spinal cord have evidence of either active inflammation or mixed active and inactive inflammation there. And so these are people who are well beyond the stopping point of DMTs, and they're very inflammatory.
Yeah. Anyway, so I think, as a community, we need to push back on this, but we need to push back with a proposal to get evidence. We can't just push back without doing some studies. Rachel?
That's going to be my point, actually. I thought it was quite interesting that Malcolm presented data that they have at NHS England where they know we're treating people with EDSS 7 and upwards. And I'm not aware of anybody that's had funding refused on that basis. So they're continuing to pay to treat these patients. And I think rather than fudge the EDSS, which we all know we're doing, and a lot of patients have an EDSS of 6.5 for a very long time, then rather than do that, I think we should be honest about what the EDSS is and then make the case to NHS England for getting those people funded properly.
Well, we'll probably do a survey. We need some. I think we need some quantitative data around opinions around this issue.